Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Good evening, Mr. Jones. It's Jane, one of the SHOs that's on call this evening. I'm calling from Ward 4 about a patient called Stephen Smith. Yeah, he's a 45-year-old gentleman, 5 days post-lap chole. Looking at the op note, it looks like it was quite a difficult procedure that was converted to open due to a difficult dissection around the bile duct. I've reviewed him as he's had an increased abdominal pain over the last couple of days, and this hasn't really settled with increasing amounts of opiate analgesia. Well, he was admitted to the ward 5 days ago after his surgery. He's normally fit and well, doesn't take any regular medications, and doesn't have any allergies. Since he's been with us, he's had some regular simple analgesia such as paracetamol, and also this evening increasing amounts of morphine. He's on day 5 of a course of oral coamoxiclav. Looking at his bloods, his white cells and CRP are showing an upward trend over the past 3 days.
Question 26. Now read the question.
This is Mr. Gervais. He's a 79-year-old gentleman. He's had general malaise over the past few months, increasingly short of breath over the past few weeks, was extremely short of breath today. 911 was called. When they arrived, he was tripoding, short of breath. His pulse ox on arrival was 69%. He bradyed down to a PEA arrest. They did 2 rounds of CPR, and there was a return of pulses in 8 minutes. And he was intubated in the field. He was brought into our hospital. Give you a little bit of history of Mr. Gervais. He has history of diabetes, hypertension. He had thyroid cancer back in 2006, which was his thyroid was removed, and also received a local radiation then. He has an allergy to penicillin. And he's currently on a hypothermia protocol post PEA arrest.
Okay.
Question 27. Now read the question.
Margot, my shift is coming to a close and it's time for bedside report. This is your new nurse, Patty. She's a great nurse. I'm leaving you in very experienced hands. And this is Audrey, Margot's daughter.
Hi, nice to meet you both. I'm replacing Sandy and I'll be with you till 7 a.m.
We're going to start report now, so feel free to add any information or ask any questions. Margot Carley is a 56-year-old that came through the emergency department and admitted for pneumonia.
Okay, Margot, can you please state your full name and date of birth?
Sure, Margot Carley, 6/26 of 60.
Thank you.
Margot presented to the emergency department early this morning with difficulty breathing, cough, and chest pain. She had a room air oxygen saturation of 84%. She has a history of a recently treated pneumonia, and we are currently giving her IV antibiotics and IV steroids through a PICC line on her right side that was placed this morning.
Question 28. Now read the question.
So this is Mr. Gervais. He is a 79-year-old male with a history of thyroid carcinoma, originally diagnosed in 2006, where he had a thyroidectomy as well as ablation, which reoccurred in April of 2009 in his thyroid as well as his lung. Also has a history of diabetes, OSA, paroxysmal atrial fibrillation, hypertension, bladder cancer, status post of TERP, and BCG, who came into the Wilmington ED arrest at home. He, at home, had been complaining of worsening shortness of breath times 1 week. When they called EMS and they arrived at his house, he was noted to be in severe respiratory distress in the tripod position with an O2 sat of 68%.
Question 29. Now read the question.
So Mrs. Jones had surgery on her back. Today is her third day post-op. She's doing excellent. She's getting up with 1 assist, utilizing the walker, ambulating to the bathroom, and Dr. Fandaka was her physician. Pain was pretty well controlled. Ranges up to a 7 at times, and taking 2 to 4 milligrams of dilaudid PO.
Okay. And you feel that your pain is getting well controlled with the dilaudid? Awesome. Right.
The last dose I gave was at 3:30, and she only took 2 milligrams, so she can have more at any time if needed. Tolerating her diet well. Do have the IV fluids running. Let's take a look at the pump together.
Question 30. Now read the question.
All right. This is Mr. Eddie Smith and his daughter Amanda. Amanda brought Mr. Smith in through the ED earlier, and he presented with some right-sided weakness, and his speech was slightly slurred. He was admitted to us on a stroke care track, and he transferred up this morning. He has a history of diabetes and hypertension, and Amanda told me that he hasn't taken his blood pressure medications in about 2 weeks.
Yes, I picked up his medicines, but he wouldn't take them.
And I've already looked at those medicines, and his homemade list is already on the chart, and it's been signed. He had a CT scan done before he arrived to the floor, and the results came back negative. And he just came back from MRI, and he has a CT angiogram ordered by his neurology consult, Dr. Elahi.
My CT was negative. Why did you run those 2 tests?
Well, even though your CT was negative, you still had to have the MRI because it's a more conclusive test, and it tells the doctor more about what's going on. It can show some things that the CT wouldn't show, so they would still order that test.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Inducing labour, that's breaking a woman's waters and making the uterus contract more strongly. Is it safe? It's an important question, and a large randomised trial has found the answer, at least for some women. The lead author was Bill Grobman, who's Professor of Obstetrics and Gynaecology at Northwestern University in Chicago. I spoke to him earlier.
What was being tested was the concept that for many years there has been a belief, really deeply ingrained, that labour induction leads to a greater chance of cesarean delivery. The truth is, though, that it's based on relatively long ago studies for which, and I'm happy to describe why, there has been a fundamental misinterpretation of the results such that we misunderstood the clinical implications.
Well, let's just talk about this misunderstanding. And just to be clear, when we're talking about labour induction, we're talking about breaking the waters and putting up a drip which makes the uterus contract.
When we're talking about labour induction, there's not a single way to do it, but that typically you're right.
So was the problem in the past that labour induction was done on women in distress and therefore it was a biased population? They were already in strife when they were induced?
Well, I think it's actually two issues. One is the issue that you already referred to, which is that so often women were being induced for a medical reason. Something else was going on. Either the fetus was in need of being delivered or the mother herself had a complication that led to delivery being recommended. And clearly those were both situations that led to a higher chance of cesarean. But the other really important thing was that the studies that were done, and when I say studies, I very much mean observational studies, not trials, but studies where people went back and looked at records of women who had delivered, were women who were being induced were compared to women in spontaneous labor at the exact same gestational age. And I think it is undeniable that if you make that comparison, that there's a greater chance of cesarean among women who were being induced than women in spontaneous labor at the exact same gestational age.
Why is that?
Well, I don't know why it necessarily is, but it just is. It's something that's observed, something that when people studied it, not with the clinical trial, but with observational data, that happened, and very consistently.
But these are biased studies because they weren't randomized.
Let me put it this way. Induction of labor is an option. I can choose to be induced or not to be induced. Spontaneous labor is not at the exact same day is not an option. Women may spontaneously have a labor, but also may not. They may not go into labor for another 2 weeks, and every week that goes by, the chance of cesarean increases. They may not go into labor and get to a point where induction of labor becomes recommended, but now it's an induction 1 or 2 or 3 weeks later. And so if you're making a clinical decision, and the clinical decision is, do I choose to be induced now or do I not? The alternative is not spontaneous labor on the same day.
It's waiting.
The alternative is waiting, which may end up in spontaneous labor but may not, or may end up in spontaneous labor weeks later. And when observational studies were constructed like that, studies that reflected the actual clinical situation, you actually very consistently did not see the association of induction with cesarean delivery.
So now you've done a randomized trial where you actually get women and you randomize them to induction or waiting.
That's exactly right. So,
and this is in women who've never had a baby before.
That's right. And so that's, I think, an important point. Most of the concern with regard to cesarean delivery was with regard to women who had never had a baby before, women on their first birth. And I should also say this isn't about women who have medical complications for which there's a medical indication for induction. This was really a question of women who had no other reason, no standard reason to have induction recommended. Was it indeed true that induction would lead to an increased risk of cesarean, or might it be, as the more recent observational studies suggested, that induction didn't increase or even decrease the chance of cesarean and maybe also improve the outcome of their baby? And
sitting behind this is a concern about a high caesarean section rate, complications in second pregnancies. You're kind of condemning yourself or committing yourself to a second caesarean, and sometimes the babies don't do as well.
I think what we would say is that, for any woman who desires a vaginal birth, that we want to do everything we can to try to optimize that chance. And clearly, if someone can have an uncomplicated vaginal birth versus an uncomplicated cesarean, both in terms of short-term complications and long-term complications, including complications for future pregnancies, it's preferable to have a vaginal birth. What we want to get rid of are unnecessary cesarean deliveries that would have potentially preventable, and the health of the mother and her child or children are preserved.
Okay, so you took about 3,000 women, not a small study. Well, it's actually, 6,000 women.
Yeah.
3,000 were assigned to labour induction at 39 weeks, and 3,000 waited to see whether they went into spontaneous labour, and they were low risk, as you said. And your outcome was mother's health, baby's health, and caesarean section. Is that right?
Yeah, that's exactly right. It was 3,000 women in each group, low-risk nulliparous women or women on their first birth, randomized to induction at 39 weeks or expectant management or waiting. And not forever, because there's still an upper limit at which in the modern day is considered sort of acceptable practice, but till about 42 weeks would be the upper limit.
What did you find?
Well, what we found was that women who were randomized to labor induction had a significantly lower chance of cesarean delivery, so about a 15% relative risk decrease in cesarean delivery. Women who were randomized to induction of labor delivered babies who were significantly less likely to need extra respiratory support, like having a tube put down their throat to help them breathe or requiring high amounts of oxygen. Women who were induced had a lower chance of having high blood pressure problems at the end of their pregnancy, sometimes called preeclampsia. And also they reported less overall pain, and they reported a greater sense of control over their labor process and a greater sense of agency.
Well, that sounds pretty impressive. We'll come back to the implications in a moment. But one of the risks here is you get the scent of the patient.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Phantom odour perception is where you perceive an odour which, when you search for it in your immediate environment, you can't find where it's coming from. In fact, turns out not to be real. Here's Serge Negus, who's a producer at Triple J, telling James Bullen of the Health Report about his experience.
How did you come to have these phantom smells?
I had a traumatic brain injury from a skateboarding accident where I fractured my skull and had part of it removed and this titanium alloy plastic mold put in there. And one of the things that my mum did when she came in was put some lavender oil on my sheets at the hospital bed, and then she presented the lavender oil to my nose and I literally couldn't smell it. And so that was when I discovered that I couldn't smell anymore. And the doctors said that it's one of the most common things that you can have happen after having a head injury is you lose basically your olfactory nerve and a lot of taste too.
How did you feel when you realised that was happening?
You can get really bad smells with these phantom smells, things like burning flesh and these sorts of things, or really unnatural smells. I didn't get that. My smells were battered fish and chips and stuff like that, and passion fruit and mango and different things like that were really nice, and they came with a sense of euphoria. So for me, I didn't mind because I'd totally lost my sense of smell. So having these kind of phantom smells for me actually worked out, but I know that for some people it can be the opposite, and they can have smells that really are quite intense and very dark, and so people actually try and figure out ways of getting rid of their phantosmia, which I don't even know if it's possible. Apparently some people have tried to have their olfactories removed completely to try and stop it, but I don't know if it even works. The science around it, it's not that strong, I believe. But my experience of phantosmia has been quite positive.
And do you ever get the bad smells, or has it pretty much been good for you?
The only time I've ever had slightly bad smells have been smells that I literally couldn't describe to you. They're so unnatural. They come from such a weird place that because my brain's creating them basically, that I'm confused by them. I'm like, what even is that? That's a smell that I've never even smelled before, obviously, because if my brain's creating this fake smell. But no, I've never had any of the bad ones. The worst thing I've had, which I actually kind of liked, was the smell of fresh cow manure. Do you ever play the game, Which Would You Rather? And I'd always say to somebody, if you said to me, which would you rather, never be able to smell again or only be able to smell fresh cow manure for the rest of your life? I was like, well, you know what? Having experienced that, I would go with fresh cow manure for the rest of my life.
And how long do they last, and how powerful are they while they're going on?
They can last for a couple of days, once every 2 to 3 weeks, but sometimes they can be a couple of months without experiencing it. But because, like I said, I've had this positive experience with phantom smells, I look forward to them when they do happen, and so I'd actually like them to happen more.
Serge Negus throwing cowpats at James Bullen. Well, head injury is only one cause of phantom odour perception. To find out how common it is and what factors might be linked to it, Kathy Bainbridge and her colleagues at the US National Institute on Deafness and Other Communications Disorders studied a large population in the United States.
For some people, they pick up an odor. It's often unpleasant, or it's often described as a burning odor. And you might ask your friend or your partner, your spouse, hey, what's that smell of something burning? And they don't smell it at all. So it's an odor perception for which there's really no source, no identifiable source in the environment.
And how bothered are people by it?
I think it varies. Some people just describe it as kind of pesky, but for sure there's a subset of people who are really debilitated by this condition and who scour their house looking for the odor. My co-author, Dr. Don Leopold, he's described people who ripped up carpeting in order to try to find the source of the odor, and there really is nothing to be found.
It's under the radar, really, this issue.
It's never been studied in such a large population as the study that I participated in.
Tell us what you did.
In the United States, there's an ongoing national health survey, and it's been going on in its current form since 1999. And beginning in 2011, we had the opportunity to add a battery of smell and also taste questions and a couple of different physical exams. So we took the opportunity to add a question about phantom odors. So we collected, over the course of 4 years, data on over 7,000 people. And it turns out that 6.5% of adults over the age of 40 in the United States are willing to